Hi everybody, Johnny and Paulina here, and we're talking about high ankle sprains or syndesmosis sprains. Uh, Not your most common type of ankle injury. So, a lateral ankle sprain involving your ATFL or your CFL is probably the most common type of injury. So, in all ankle injuries, 97% of the time the ATFL is ruptured or torn. Now, for a high ankle sprain, what are we talking about? Well, we're talking about the syndesmosis joint. And that is the joint between the fibula and the tibia. And you've got two of those. You've got a proximal syndesmosis joint, so a proximal tibia fib joint, and a distal tib fib joint. And we are looking at the distal tib fib joint. So here's your talocrural joint, which is your talus, fibula, and tibia, and that helps with dorsiflexion, plantar flexion, does a little bit of inversion, eversion, but that mainly comes from the subtalar joint. So the syndesmosis joint comprises of some tissues. So you've got your interosseous membrane here, and at the bottom of it you've got your interosseous ligament, and then you've got your AITFL. So that's your anterior, there's your superior, inferior tibiofibular ligament, because that's where it goes across, and it stops these two guys splaying across too much. And then you've also got at the back, you've got your posterior inferior tibiofibular ligament, as well as your transverse ligament, and they kind of one sits above the other, and so in some anatomy books they're the same ligament. So again, you've got your interosseous membrane, interosseous ligament, anterior inferior tibiofibular ligament, and your posterior inferior tibiofibular ligament. So you've got a few structures that keep the fibula and tibia nicely strapped together. So if you're looking at injury incidence, if the ATFL is the most commonly injured, then a high ankle sprain, you're looking at between, for every 100 you might see 12. So, between a 12 and 16% chances of this happening. It comes down to the mechanism of injury, really. So what happens is that the tibia, I'll use Paulina's, so you get this external rotational stress on it. So what happens is the knee is bent, the foot is out here like this, and this is the tibia rotates on the talus, and the foot is usually planted and in dorsiflexion. And what happens is that there's such an external rotational force on it that it may injure the AITFL or the interosseous ligament or other aspects of it. So you've got this one here. So we have a test for that, which is called the external rotation test, and this tries to mimic the mechanism of injury. So we've got the patient sitting at the edge of the bed, and a knee is flexed to 90 degrees, and then the thigh is fixated by the bed itself. And the idea here is that we're going to dorsiflex. We're going to bring the toes to the nose, because with dorsiflexion what happens is that you already put a stress on the tibia and fibula. Because what happens is that when you go into dorsiflexion, the mortise, so this widens, okay, because the talus is an irregular shaped bone. And what happens is that when you go into this dorsiflex position, more of the talus goes into the mortise, and it spreads the distance or the gap, or it spreads the tibia from the fibula. So the test would be done by putting your hand underneath, bringing the patient into as much dorsiflexion as they can tolerate at the time, and then externally rotating the patient's foot while fixating the tibia. Now, if they report pain or their symptoms on that test, that's a positive sign for an AITFL injury, so a high ankle sprain or syndesmosis sprain. Couple of other things that need to occur as well. So it needs to be tender on palpation, so tender to touch over the AITFL, to increase the reliability of or validity of this test. plus the mechanism of injury. So, you know, if they're a collegiate athlete, if they're a contact athlete, if they're an athlete that's got change of direction involved, then, you know, you're more likely to see this type of injury in those type of athletes. So your rugby players, lacrosse players, your NFL players, and so on and so forth, they suffer high ankle sprains a lot more than other types of athletes. Now, the problem with the external rotational stress test is that it's not very specific or very sensitive, which means that if you really want to know if the AITFL, if you've got a high ankle sprain, you should probably be looking at an MRI. However, if there's an area of swelling and they're tender to touch, they've got a correct, or they've got an appropriate mechanism of injury, and the external rotational stress test is positive, then you would have a high clinical suspicion of some type of injury going on around here. If you wanted to be specific to the structures, then an MRI is probably warranted at this stage. And really what you're looking to see is that clinically, before having in a picture, is the patient stable or not? Do they have a sense of functional stability, or so a perceivement of, do you know what, my ankle just doesn't feel very stable? Or is there actually some, you know, pathomechanical laxity going on? So you've got a diastasis, you've got a real splay of the fibula to the tibia. Again, that would be very, very hard to diagnose clinically, and even radiologically. They've shown that there's no real correlation between the diastasis, so the distance, the increase in distance between the tibia and fibula, and those patients who are clinically stable, or those patients who just can't kind of function with a high ankle sprain. So again, important to note those points. So hope you enjoyed that.